You wake up and go to work one day. You're slow in your movements since you are still recovering from being treated for low back pain at UNC Medical Center. You begin to open the mail and get an odd letter from UNC Health. It says that your personal information may or may not have been exposed during a recent cyber phishing incident. While you're not sure what that means, the letter mentions that the attack happened a few months ago during your preoperative care, and that the information impact could include your address, health insurance information, and even social security number. While this incident may sound too scary to happen, it is real. In fact, this particular letter was mailed to about 3,716 people back in 2019 by the University of North Carolina at Chapel Hill School of Medicine. Cyber attacks happen all the time. Hospitals and clinics are often targeted due to the high volume of sensitive information that they possess. To understand how these attacks came to be, it's important to start by looking at how we store and protect medical information. This is Devin Desai, and I'm here today with Clay Baker and Narushi Bhatia. Today, we are excited to explore how electronic health records came to be and see how all the different stakeholders in the healthcare system come together.
Diving into the history of electronic health records, the concept of storing medical information about patients, known as keeping medical records, dates back as early as ancient Egyptian times, with hieroglyphs indicating some sort of method of keeping track of information that was relevant to a person's health. Fast forward thousands and thousands of years, and we see that in the early 1900s, the concept of paper records gained a lot of traction. The purpose of these records was to store longitudinal data about a patient in a care delivery setting. This can mean information about demographics, medications, prescriptions, any scans, blood reports, and basically anything under the sun in relation to health data. This quantity of data is actually one of the reasons the name of these paper records changed from their original name of medical records to health records, which sort of allowed for a more holistic description of a patient's health. In the late 60s, the first versions of what we now know as electronic health records, or EHRs, began to develop. Electronic health records essentially were created with the same goal in mind as paper records, except with the feature of being able to be shared across multiple stakeholders, edited at the same time, and being able to be stored in a more secure and centralized place across multiple stakeholders as well. Electronic health records officially began with Lockheed Corporation's version, which prioritized having multiple users updating and viewing the record at the same time, and also prioritized computerized physician order entry. Similar efforts were seen in other places, such as the University of Utah and Massachusetts General Hospital, which prioritized other features, such as efficiency and recognizing multiple words that meant the same thing. For example, being able to recognize COVID-19 versus COVID versus coronavirus and versus SARS-CoV-19, and being able to recognize that they all meant the same thing.
Naturally, as computers and the internet became more prevalent, and more importantly, affordable and portable, technology began to integrate itself into the healthcare sphere, starting first with academic medical centers in the 70s and 80s. Additionally, in the 70s, the government used EHRs for the Department of Veteran Affairs, which was a huge step in increasing EHR use. This EHR system is actually given a lot of praise because there are so many people that monitor and review the records in order to reduce the prevalence of errors. Many academic centers started off with developing their own EHR systems, so there was a lack of consistency in the record across the board. However, in the 80s, there was a push towards standardizing the EHR format, and soon, in the 90s, the cost of computers was low enough to justify its use across the board in hospitals, clinics, and other healthcare places, and the use of electronic health records was even encouraged by the Institute of Medicine through the publishing of various papers that demonstrated the benefits of using electronic health records. But integrating this didn't come without pushback. There was no real motivation for the physician side to use electronic health records that was worth having to learn an entirely new system. And the electronic system alone was a conduit for misspellings, security issues, cost, and other errors. There initially seemed to be more cost than benefits, and because of that, the integration of EHR wasn't this initial rush towards an all-magical, perfect record-keeping system. However, with additional support for physicians in transitioning to EHR use, the development of additional standards for EHR use was a big improvement. There is a functional model titled HL7 EHRS, which essentially enumerates the standards needed for EHRs to achieve their goal, such as aiding with the financial aspect of healthcare like billing, facilitating faster and easier communication across stakeholders, and more. Since 2006, HL7 has been seen as sort of the standard as well, with the Certification Commission for Healthcare Information looking at the EHR format of different vendors and certifying if they meet HL7 standards.
Looking at electronic health records, relevant policies are also important to examine. HIPAA was signed into law back in 1996 with the mission to improve the portability and accountability of health insurance coverage. HIPAA modernized information flow within the healthcare setting and also set out to increase the number of Americans who had health insurance coverage and provide coverage for individuals who are between employment. The law only applies to certain covered entities, which is one of the following: a healthcare provider, a health plan, or healthcare clearinghouse. A healthcare provider could be a medical doctor, clinic, and nursing home. Covered health plan entities include health insurance companies and government initiatives that could facilitate payment for healthcare services, and this could include Medicare or Medicaid. Finally, a healthcare clearinghouse is a covered entity that transfers health information or serves as the middle person between insurance companies and healthcare providers. Since these covered entities cannot conduct all of their functions and services alone, the privacy rule, which we will discuss soon, added language to extend coverage to business associates. Under the Department of Health and Human Services, or HHS's guidelines, a business associate is a person or entity that performs certain functions or activities that involve the use or disclosure of protected health information on behalf of or provides services to a covered entity. To be recognized as a business associate, the individual or entity must be directly involved with the healthcare plan or provider and not simply an employee at the company themselves. Examples of business associates include CPA firms involved in providing accounting services to a healthcare provider, consultant for hospital, legal service provider for cases involving healthcare information, and more. There are also extended coverages provided for contractors and business associate contracts. However, the rules often stipulate certain forms and disclosures must be announced before coverage can apply. HIPAA also legislated that the Secretary of the Department of HHS provide standards for the regulation of personal health information through avenues such as HIPAA, security, and privacy rules. The privacy rule details how to safeguard protected health information. The Office for Civil Rights was also given enforcement power for HIPAA compliance. This rule also details 18 protected PHIs. The security rule set national standards on what PHI should be protected. The same rule also extended existing protection to electronic information. In 2006, the enforcement rule was passed to give HHS the power to enforce HIPAA compliance, investigate violations, and conduct hearings.
In 2009, the Health Information Technology for Economic and Clinical Health, HITECH Act, was used to promote the use of health information technologies, or HIT, for those providing Medicare and Medicaid services. The HITECH Act established the Office of the National Coordinator for Health Information Technology and other committees that set standards and specifications for what constitutes HIT. The Act also had stipulations on what federal agencies using HIT had to abide by, especially in regards to testing, research, grants, and other similar processes. From a security perspective, the HITECH Act also introduced protection of privacy and security into HIT storage through audits and other methods. Overall, the Act incentivized sharing health information with relevant stakeholders, but also raised concerns on building the necessary technological infrastructures to support secure and protected data sharing.
More recently, the 21st Century Cures Act became a law. The Cures Act was legalized in December of 2016, and it was an extension of the U.S. Food and Drug Administration, or FDA's, work to combine patient perspectives with innovation. The Cures Act modernized clinical trials, but also enhanced patient autonomy in choosing and accessing information. One of the most important provisions of the Cures Act was requiring Health and Human Services to adopt the interoperability and information blocking rule, or the final rule. The first part of this rule, which refers to the interoperability aspect, was introduced to allow for the secure exchange of e-health information without restricting the user and also allowing for complete electronic access to health information for authorized users in all legal contexts. The second part of the final rule details how information blocking is prohibited. Information blocking refers to any process in which an organization or practice prevents or even discourages the use, access, or sharing of electronic health information when it is known by a party that the use, access, or sharing of e-health information could be hindered. The Cures Act was arguably one of the most revolutionary changes to electronic health information sharing since HIPAA on a federal level. Under the final rule, hospitals which operate under the Centers for Medicare and Medicaid Services, or CMS regulation, have to send notifications when a patient is admitted, discharged, or even transferred whenever that information is asked for. While the final rule on interoperability and information blocking may seem complex, it is important for safeguarding access to electronic health information. Furthermore, the Cures Act also specifies that information blocking can lead to fines of up to $1 million per violation found. This act importantly established that patients have a right and access to their own information, which was not explicit in previous legislation, especially for electronic protected health information.
Today, it is pretty easy for us to see how EHRs are extremely prevalent in healthcare. Most physicians have abandoned the use of the traditional pen and paper health record and instead rely on their laptop for rapid data entry. This is what allows us to go to our doctor's appointments and within minutes have LabCorp send over our blood test results, view this entire record from our home, and have the doctor make the most informed and best course of action. Of course, we'll get into many of the drawbacks and weaknesses that still come with EHRs, but needless to say, there are many undeniable benefits that have come from its use. Electronic health records have been quite successful at meeting some of their core goals, providing a central location for the recording and accessing of medical information. They provide physicians with clinical decision support. Beyond that, the integrated system allows you to place orders online. Can you imagine a world without electronic prescriptions? Now, pharmacists no longer need to decipher a physician's handwriting or triple-check interactions between medications. EHRs, through automation, vastly simplify this process among many other treatment processes. Surely, when a patient goes to a large health system, such as Duke or UNC Health, their records from different specialists are collected and stored together. Information sharing for a new appointment is almost seamless. Or is it? Only when you are in the same EHR system. But when a patient goes from a provider using one service, like Epic, to another service, their notes are suddenly not as integrated. When it comes to health information exchange, EHRs have only begun to reach their potential. And by failing to communicate across systems, that is, failing to have interoperability, these systems, more times than we would like, create inconveniences in the healthcare sphere, especially regarding the best patient treatment and ensuring that patients are working with the best physicians for them.
It seems obvious that working together would benefit patients and physicians alike. Why then are EHR providers not best catering to these audiences? Well, the answer is complicated, and in part, it lies in the heart of American society, focused on promoting free and competitive commerce. To explain this further, let's go back to 1914, when the United States passed the Federal Trade Commission Act, establishing the Federal Trade Commission as the government agency for consumer protection and, importantly, preventing anti-competitive business practices. At the same time, Congress also passed the Clayton Act, which bolstered the United States' stance against antitrust, specifically preventing anti-competitive mergers, or arrangements between companies, predatory pricing practices, and generally unethical corporate behavior. How does this relate to EHR? Well, cooperating between EHR providers, whether it is them sharing a patient's financial information, allowing another provider to see your proprietary system for structuring and storing patient data, among other things, raises concerns over antitrust practices. And unfortunately, with the structure of HIPAA, High-Tech, and 21st Century Cures Act, there was not much legal policy in place to mediate these concerns or questions. Rather, these acts promoted the rise of many different EHR systems throughout the United States, all built with slightly different interfaces. Though a few major EHR providers, Epic, Cerner, and Allscripts, hold the vast majority of patient records and provider contracts, their interoperability, or lack thereof, creates tension between providers, patients, and physicians.
To better understand how antitrust applies to electronic health records, it's useful to look at some examples. Also, antitrust refers to practices put in place to promote competition and reduce monopolies. Now, back in the early 2010s, the sale of Salzer Medical Group to the St. Luke's Health System in Idaho was invalidated by a federal judge on the grounds of antitrust. It was found that both groups engaged in information blocking, which was outlawed by the 21st Century Cures Act. Essentially, the St. Luke's Health System was tracking medical referrals and requiring them to go to in-network doctors within their health system. Emails even indicated that doctors, quote, need to do a better job of keeping referrals in-house, end quote. St. Luke's Health System even noted in messaging that emergent care should be done with doctors in the health system for the most efficient and effective care. Merging the two largest health systems in the Boise area would have created a monopoly of health services in that area, which was the primary reason why that merger was invalidated. In this example, we can see that information blocking and merging of electronic health records would have diminished the quality of healthcare providers. The merging of the health systems would be beneficial for health information sharing purposes, but with the allegations of information blocking, medical care would be at risk and so would quality.
Another antitrust lawsuit was filed by the Federal Trade Commission, FTC, against the health IT company SureScripts. SureScripts is a technological company that focuses on supporting electronic or e-prescriptions and the exchange of the prescriptions and basic health information that is typically found in the medical records between healthcare providers and organizations and pharmacies. A formulary is a list of medications and drugs that is used and cross-referenced with your health plan, so you're receiving safe and effective but also affordable medication. And so it is important to share information across these providers so that the use of the formulary is encouraged. The FTC found that SureScripts allegedly engaged in electronic routing, which is the exchange of a patient's formulary and benefit information from a payer to a prescriber's EHR system. By controlling over 95% of the market in this space, SureScripts has been able to keep long-term partnerships with providers and drive out competitors before they could get a footing in the market. The company also created partnerships and contracts with 81% of the EHR routing market, including large EHR companies such as Epic. In this case, electronic health information was being shared across the network to automatically set up files and profiles in SureScripts, which could drive up costs for the patients. This case study shows how electronic health records are being misused to favor profit at the detriment of proper health care.
In retrospect, electronic health records have gained prominence due to their ease of access and use by both healthcare providers and patients. As they continue to develop and grow in use, it is important to keep exploring the security of EHR regulations and ensure that privacy regulations are continuously updated to enforce our safety. We thank you so much for listening to us today, and we hope that you learn more about electronic health records. Be sure to check out our other written supplements below to explore some of these topics in greater detail. Thank you.